Uh, James Dankert there. James Dankert from Psychology. He'll be talking about high-resolution functional MRI in patients with epilepsy, imaging the abnormal brain.
My talk seemed like I'm doing geomatics. Great, thanks. I'd also like to thank the organisers for the opportunity to come and talk about some of my research here and to sort of get some really disparate people together to think about what we can do at Waterloo to improve our capacity for this kind of imaging. I'm lucky enough too to have had Rich Staines present before me, so now you're all experts in fMRI and the bulb response, and I don't need to tell you all about that, which is very lucky for me because I wasn't going to anyway. I'm going to talk to you about work pretty much largely conducted at a 4 Tesla functional MRI facility in London at the Robarts Research Institute in collaboration with doctors at University Hospital there, in which we look at the functional organisation of very basic cognitive skills in patients who have fairly unusual abnormalities in their brains that are sort of the cause of epilepsy. There's several kinds of issues that we need to sort of deal with in this kind of imaging of patients with epilepsy. One is a pre-surgical evaluation sort of question, and Myra Fernandez will talk to you a little bit about that later on. Just quickly though, the WADA technique is one in which a patient has basically one half of their brain anaesthetised, so you can try and examine the function of the unanaesthetised or the unnumbed half of the brain. If we can demonstrate that fMRI provides a reliable measure of this kind, it's a much better way to go because it's non-invasive. So there are important questions to be asked there. Also, for patients for whom their epilepsy is not responding very well to the medication, so they've had the appropriate medical sort of treatments, and they're still presenting with seizures that are uncontrolled, surgery is an option to remove the epileptogenic tissue, that tissue that's the origin of the seizure focus in the patient. And it's really important for us to do some of the stuff similar to what you heard from Rich Staines, to look at pre- and post-surgical function in these patients. So was the tissue that was there beforehand that was generating all these seizures, was that actually demonstrating normal function in the first place? And even after that, when we remove that tissue, what kind of recovery of function do we see? Do we see a reorganisation of function or some kind of recovery of perilesional sort of tissue? But I'm not going to talk about that. I'm going to talk mostly about just evaluating unusual cases. And you've just heard a little bit about that. Very, very briefly before I talk about the very unusual case, I'll talk to you about this pre- and post-surgical evaluation. You're looking at an image there, a coronal image, so if you slice through the brain in this way, of a patient looking at a moving stimulus, so a range of moving dots. And the whole back half of the brain, your occipital cortex, lights up like a Christmas tree. This is because this is the part of the brain that basically processes visual information. But there's an important area to the left here, known as area MT or V5, that's important for processing visual motion. And it turns out that then this part of the brain, if it's removed in that patient as a treatment for their epilepsy, we might want to then go ahead and do functional imaging to determine whether or not around that, so perilesional, around that sort of lesion, that removed tissue, they've demonstrated any recovery of function. I don't have recovery of function images in this patient. That's just to sort of present to you that these are the kind of issues that we would look at. And co-registering this post-surgery image to the pre-surgery image is one of the imaging sort of quandaries that is really important for us to try and overcome. But what's perhaps more interesting are these cases that have congenital abnormalities. They're born with some kind of abnormality, either of tissue or, in this guy's case, a porencephalic cyst that originates from the ventricle. And you saw in a couple of talks ago mention of hydrocephalus. This looks a little bit like hydrocephalus. This is a cyst that's filled with fluid and has invaded some part of the neural tissue and pushed that tissue apart. And the essential question for this patient was, on that left-hand side of his brain, the remaining tissue, unfortunately for him, this was the tissue that was generating his seizures. So the question was, can surgeons go in and remove that tissue, and what will the functional consequences be if they go ahead and do that? So we then use fMRI to have a look at this kind of thing, and like I say, we're looking at very basic functions. So to look at somatosensory information, we just have a wooden pole with a ping pong ball on the end of it, and in the upturned palm, we stimulate the patient's hand. The grey areas represent no stimulation here, the green areas represent stimulation, and you can see that in that left hemisphere he's still showing an ability to process somatosensory information. Similarly, we might get him to do simple fine motor control tasks, so a finger tapping task where he just alternates tapping his index and middle fingers, or a more complex task where he does something like this, where you alternately tap each finger to your thumb. And again, in his left hemisphere, when he's doing this kind of movement with his right hand, you get activation that is associated, more activation for the more difficult task than you see for the simpler task. And I'm going to just sort of move on. The basic story is pretty much the same. We also show activation in that remaining portion of tissue for language functions. And so the bottom line for this guy was that you really shouldn't remove that tissue because you're going to wind up producing quite dramatic impairments and deficits in that patient, so you should resort back to more medical sort of treatments, more pharmacological sort of treatments. So what are the issues that are important in terms of imaging in this symposium for this kind of work? Well, we're dealing typically with a sample size of 1 because you're not likely to get 2 patients that look the same. So that comes normally when we do functional imaging, we do it with a larger group, 10 to 12 sort of people. We can average the data from each of those individuals and get more statistical power. How can we bump up the power from the images we obtain to get appropriate sort of images when we've only got 1 subject? Other sort of questions about what's normal in an abnormal brain like that. What can I sort of take to be a reasonable kind of image, an interpretable kind of image? And also to look at sort of subtle versus gross changes. So much like the hydrocephalus talk that you just heard a second ago, we can look at different sorts of levels in using this kind of technique. What are the gross changes that we can detect, and what are the more sort of subtle or fine-grained sort of changes? Thank you very much.
Questions or comments?
Yeah.
Jeff?
Interesting. How do you anesthetize half the brain?
It's a sodium aminobarbital test, and you actually inject that chemical into one internal carotid. As it turns out, your blood supply to the brain is bifurcated. So you can just choose one internal carotid artery, and that will provide the blood supply to just one hemisphere. And so if you selectively place your anaesthetic into that carotid artery, you'll anaesthetize that half of the brain. And then you do a range of sort of tests to say, is language in this hemisphere or that hemisphere? What's their visual versus verbal memory? This kind of thing.
How long does that last?
5 minutes.
It's amazing.
Yeah.
I need that.
I actually wouldn't mind doing it just for fun one day, but I don't know that the ethics is going on.
That's fascinating. What happens to consciousness?
Well, I mean, Myra can also sort of address some of these questions probably better than I. She's more familiar with the technique. The patient is still capable of responding in certain instances, especially if I anaesthetize the right hemisphere. We have most of our language capacities in the left hemisphere, so I can ask you questions and you can still speak and respond. You might have slurred speech in some ways because you're not quite controlling your tongue and lips as well as you can. And you can do other kinds of things. You can point. So if I give you a task in which your answer has to be chosen from 4 visual options, where you can point to which option you like, and so on and so forth.
Time for one more comment or question. Bob?
What exactly are you imaging, and you need 4 Tesla to do that?
So it's a good question. What's available at Grand River, as you know, is a 1.5T, and what we need to do is to make that functional ready, which is basically implementing software that upgrades the magnet, and then having some hardware that allows us to deliver images into the magnet so that we can have patients and subjects do tasks. The Tesla, so the strength of the magnet is important depending on the question that you're going to be asking. So if I wanted to image ocular dominance columns in the occipital cortex, so one column that sort of is dominant for your left eye, one for your right, so on and so forth, these columns exist at a sub-millimetre level. So I need a high-resolution scanner in order to detect them. 4T, and now available for human use is about 7T has been approved. To do the kinds of things that I showed you there, the much more basic designs, much more basic sort of questions, no, you can do it on 1.5T. So it's about the question you're asking and then the design of the experiment. And we don't really have time to go into those kinds of things. I can talk to you about it later if you like.